Thank you very much. It was very an intuitive talk, academically very sound by all the three speakers. We have some questions which we will now open up. And Geetanjali, would you like to take any question first?
Yes, sure. I think first question is for Dr. Patil. The question is whether ERA can be offered in recurrent pregnancy losses, or let's say recurrent implantation failure. Does it have some utility?
No. So just one thing, Madhuri, let's make very clear to the delegates that RPL is different from RIL. So let's make that difference before we answer this question.
Yeah. So basically, recurrent implantation failure is wherein you've done many embryo transfers and the patient and the embryos fail to implant. Whereas recurrent pregnancy loss is wherein there is an implantation, there is a pregnancy, and the patient has failed the pregnancy. So ERA basically is done only to only those patients who have recurrent implantation failure, and it does not have any role in recurrent pregnancy loss.
So as an extension of this question, Dr. Coutifaris, where we say recurrent implantation failure, where we say that person has failed at least 3 times by different definitions, there are 72 definitions of RIF. But suppose there's an older patient who has had one failure and she has very limited number of embryos which are PGT-A tested. In that kind of a circumstance, would you offer an ERA?
I think so. And again, we don't have the study, so we have to use a clinical judgment and decide. From Dr. Simon's study, which I presented, and I took the time to go through it in detail because unfortunately it's getting pushed to do it, to do the ERA on everybody. But when you look at the study, that's not justified. But in that study, there is a difference if an ERA was done between frozen embryo transfer and personalized embryo transfer. And I pointed this out towards the end of my discussion. And this was only after one transfer that had failed. So regardless of age, there may be a place to proceed with an ERA after failure of a frozen transfer. So not if it's the fresh that failed and we go ahead immediately with an ERA, but if there is a frozen transfer, either first or the second transfer, if it fails, I think it's reasonable to proceed. And as you mentioned, certainly the older patient who has very few embryos, it would be appropriate. So that would be my recommendation at this stage. But we don't have the study to prove that, but we have to use our clinical judgment.
So continuing this discussion, Dr. Coutifaris, if you were given a report of somebody being non-receptive, but one patient being prereceptive and one being post-receptive, from your clinical experience or your gut feeling, do you know which patient would do better with a personalized embryo transfer?
Well, the right answer is I don't know. But the majority of patients are prereceptive. And that means that there is delay in the development of the endometrium. And therefore, if all you have to do is add a day or so to the transfer, or 2 sometimes, depending on the recommendation, I think that has a better chance at success. I don't understand the biology of delayed biopsy. Yes, it can be there, but maybe an error was made when the biopsy was done. And maybe that's why we're seeing so few being in the late. But no, the one that I will have more sort of an optimistic view would be the ones that are pre-receptive.
There's a question to Dr. Kelly and to Madhuri. Dr. Kelly, are you there? Okay, so Madhuri, while waiting for Dr. Kelly, I'm going to ask you this. You mentioned about peristalsis. Now, is it something easy to pick up, and how long does one need to probe the patient in order to actually see the peristalsis?
Yeah, I mean, if you have a good quality machine, when you're doing your scans, you can just see the peristalsis of the endometrium. And basically, I mean, if at all, you require about 2 to 3 minutes extra. Otherwise, the peristalsis are very well seen both in the luteal as well as in the proliferative phase.
So, Madhuri, I didn't understand this. Are peristalsis good or peristalsis bad for implantation?
No, they have to be in a particular way. So basically, when in the proliferative phase, basically they are fundocervical because it's coming down. But in the luteal phase, they have to be cervicofundal because normally the cervicofundal are post-ovulatory because the sperms need to travel all the way into the tubes. And even during the when we do the embryo transfers, probably that. And one of the reasons for an ectopic pregnancy is an excessive cervicofundal peristaltic wave, which pushes the embryo into the tube and resulting in an ectopic. And therefore, we say that they have to be less than 2 because if they are more than 3, what happens? The chances of an ectopic pregnancy increases. And if they are the other way around, that is, if they are fundocervical, again, the embryo could be pushed out of the cervix. So basically, they have to be post-ovulatory, they have to be cervicofundal and they have to be less than 2. So you can very well see them, like I showed the video. I mean, that's from my clinic itself, and you could really see the peristalsis very well.
So, Dr. Patil, thank you for giving a very comprehensive overview of endometrial receptivity markers. So, what do you think, like, is it a good idea to take out part of uterine fluid for checking receptivity without affecting, because there are animal studies which indicate that yes, uterine fluid is also important for implantation. So,
yeah, so there are many papers which have been published, but I think we in India do not have the facility wherein we can analyze the uterine fluid. So I really would not know the clinical implications and how good it would be to our patients in improving their pregnancy rates. But I think looking at the different papers studied, and if we have a good evidence for it in future, they could serve as good markers, because it has been shown that when you aspirate the fluid, it really does not influence the receptivity, and therefore it can be done in the same cycle. But most of the endometrial markers, what I mentioned also, though I think ultrasound is used the maximum, but all of them have more of a negative predictive value than of a positive predictive value. So this is very important for us to remember that that it doesn't, none of the markers, though whatever we study, have a positive predictive value. But they do have a good negative predictive value.
I think you are right. There can't be a single marker for detecting receptivity. So can we have some kind of prediction algorithms based on different markers which have been analyzed so far?
Yeah, so basically what in India especially, what we look at is the ultrasound, because it's available to most of our patients, and the 2 or 3 markers which all of us regularly look is at the thickness as well as at the morphology of the endometrium, and there are a few who also do the Doppler, because I think 50% must be doing Doppler, the other remaining 50% don't do the Doppler. And in my FET cycles, I feel, and especially when the endometrium is thin, I feel doing the endometrial volume is very, very a very good marker, especially when you're doing the FET cycles, because what happens is sometimes if the endometrium does not grow, and then and though the blood flow may be okay, it might be in zone 2, but if the endometrial volume is less than 2, at least in my practice, I have seen that the implantation rate is very, very low.
Dr. Coutifaris, a question for you. Sorry, go ahead.
Before the question, I would like to make a comment about the future, and I agree with everything Dr. Patil said. That in terms of the future, when we are able to identify secretory markers in the fluid, whether it's cervical secretions or really, since we don't damage the endometrium, aspirating the fluid from inside the uterus, it would be wonderful, once this is defined, to be able, the morning, let's say, of a planned transfer, to do the quick test. If the quick test shows receptivity, then you thaw the embryo and you do the transfer. If not, either you repeat the next day, or depending on what your results are. I mean, that would truly revolutionize the field. We are not even close yet, but I think everybody listening today, I think, should sort of look forward to something like this for the future, because the molecular expression studies will have to be translated to secretory proteins that then we can identify, hopefully with a quick test, and then plan the transfer. Anyway, nothing to be done today, but certainly something to look forward to.
Yeah, because probably it could be done in the same cycle, because most of the other studies, I mean, the molecular studies are done in a non-transfer cycle. So probably this would really help us in improving and optimizing the ART outcome.
And the other thing you just reminded me I need to mention is the cycle-to-cycle variability of the ERA, even though it's claimed to have been defined, it really hasn't. It was not a planned study to see what happens from cycle to cycle. It happened to be, I think it was 7 or 9 patients. It's been published, but it has been 7 or 9 patients who had a second biopsy either in the following or 2 cycles later, or in some cases, many, many months later. I think in one case, it was years later, and it showed that there was no difference in the ERA, and that concluded that there's no difference from cycle to cycle. Really, the study has not been done. The cycle-to-cycle variability needs to be evaluated appropriately before we can say what we saw this cycle holds for the next cycle.
Yeah, and moreover, I think it's very expensive, and because they said that we have to revalidate it. So again, revalidating incurs an expense to the patient. So I don't know in India how many of us really revalidate it, or probably we just use what is said in the first test. Because if you tell the patient that you pay another 40,000 in the Indian currency, I mean, they're really not ready for it. So this is another thing which we need to keep in mind, whether we should use the ERA just doing by a single test, should we revalidate it, or whatever that if it's pre or post receptive in the first test, we need to do the personalized embryo transfer, taking into consideration the period of time given by the results.
So, just to add on, Dr. Patil, as you are very right that there can be discordance between RNA and protein studies. So ERA is just looking at transcript levels. So we need to look at protein levels. Those would be better indicators of receptivity rather than just RNA. And people are now looking at exosomes in the uterine fluid. So probably that would be a better way to go ahead. I think so.
Yeah.
Yeah.
So then in that case, if ERA is expensive, would it not be better to do an ERA in this month and offer the FET or a personalized embryo transfer in the subsequent month, hoping that there's not too much variation? Although there are studies which say that you can wait till 34 months before the result actually changes. Yeah, Madhuri, would you like?
Yeah, that seems better idea. Yeah.
No, we can do it in the next cycle, but I mean, we are really not sure because normally we do it in the next subsequent cycle as well. I mean, itself. So, but I have done it in about 37 or 38 patients, and out of that, I think there must be only about 6 or 7 of them which had an abnormal receptivity analysis which was done, and out of those 7, I think only 1 patient must have conceived after I've done a personalized embryo transfer.
The other thing that I think we need to point out is, even though I think all of us use it both in programmed cycles and in natural cycles, ERA, actually there's no study in natural cycles. And we really don't know in a natural cycle how we can use it, whether it's similar to the programmed cycle. So that's something else that I think everybody needs to keep.
There's an interesting question. Dr. Kelly is not there, so I will open it up to the other 2 speakers. You have 2 embryos, one which is 20% mosaic on day 5, and there is a euploid embryo on day 7. Which would you choose? The mosaicism only 20%.
So probably we can freeze the day 7 embryo, which is euploid, and transfer it in a subsequent frozen embryo transfer cycle. If she's ovulatory, I prefer doing a natural cycle for most of the patients if they are ovulatory. Only if they are PCOS, then I would do a HRT cycle. So depending on what it is. So I think day 7 euploid embryo should be frozen because it has been seen that it's basically the embryo endometrial asynchrony which does not result in a pregnancy if we transfer a day 7 blastocyst because the endometrium would have become post-mature by then. So I think it's better that we transfer the euploid embryo which is there on day 7 in a subsequent cycle.
No, these are both frozen, Madhuri. These are both frozen. And now you are being asked
So I would transfer a day 7 one.
Dr.
But it
Coutifaris?
won't make a difference on the implantation rate.
Yes, I would put, actually, I was going to joke is I would put the day 6 embryo first, but since she went to the two extreme, I would put the day 7 embryo euploid first, freeze the mosaic, and then do the mosaic later.
So there is, Dr. Kelly's not there, but she brought up a very wonderful observation that in their registry, they found that the infant mortality rate was high. Now, do you think these are imprinting disorders which are giving rise to this higher mortality? We don't know what was the cause for this mortality. Any kind of light that can be thrown by any of the other speakers? I'm sorry that Dr. Kelly is not there. She would have been very appropriate to answer this question.
It has also been seen that, the freezing and thawing itself is a process which can induce epigenetic changes. And therefore, whatever the abnormalities, because there were several papers which were published recently, have said that this could result in epigenetic and imprinting disorders in the children. And therefore, probably the reason why Dr. Kelly said that there was a perinatal problem which they had noted. I always would prefer doing a fresh transfer whenever possible. I don't like to defer a fresh transfer in most of my cycles, unless really when there is a very high risk of OHSS, which I think with the use of antagonist has not been there for the last several years with me. So I don't do freeze all for none of the normal responders or the poor responders. I don't believe in doing it.
I think we're going to discuss this a little bit more tomorrow also, but I think that we've been doing program cycles for so long, and I wonder whether some of the results from that study have something to do with some of the placentation abnormalities that now are sort of coming up, which may have, by the way, an epigenetic basis. That's actually part of research that I'm involved in, basic research. But it's very hard for me when we look at so many years of results where slow freeze, vitrification, probably mostly program cycles, to then say, oh, we shouldn't be doing frozen transfers now on everybody because there is higher infant mortality. Because still the success in cases, and we'll talk tomorrow about PCOS, for example, in PCOS, the almost criminal to do transfer in a fresh cycle, given the risks to the mother potentially. So anyway, that's my 2 cents. I think there is a placentation issue that may have long-term effects to the baby, or the freezing and thawing in terms of the epigenetic makeup of the actual fetus and then newborn. But that remains to be seen.
So we had a very enlightening session. Our time has run out, and we are looking for a wonderful discourse tomorrow. Thank you, Duru. Thank you, Madhuri. Thank you, Geeta. Thank you, Dr. Coutifaris and Dr. Kelly, for enlightening us on this very important topic. Good night. Have a safe weekend.
Thank you all. Thank you.
Well, thank you so much.
Yeah. I would just like to give the highlights of today's program. So I think all our speakers have really done a great job. And in the first session, we had Dr. Jatin Shah, who spoke on in which patients we should do freeze all, though he said he does in most of his patients. But I think it should be done only in patients who are hyperresponders, or wherein we have done a PGT-A. And the evidence does not support doing freeze all in all patients, and basically it also increases the time to pregnancy, which we should take into consideration. Dr. Nalini Kaul, in her talk on effect of COS on oocytes and embryos, clearly pointed out that COS do have an effect, and especially when there is increased incidence of retrieving immature oocytes. And she also said that there's also an increased incidence of having a lot of SERs, which can then affect the embryogenesis as well as the perinatal outcome. And she also mentioned about using of high dose of gonadotrophins resulted in maturation of poor quality oocytes, which then increases the risk of aneuploidy, and therefore individualized protocols are most important. Dr. Fleming spoke about freezing of day 3 or day 5 embryos, and he said that each of freezing either on day 3 and 5 have different benefits and limitations. But he also said that trophoectoderm biopsy and vitrification of day 5 embryos has a better live birth rate than that of day 3 embryos, and basically there is no difference in the clinical pregnancy rate as well as the live birth rates in the first frozen embryo transfer, whether the embryos were frozen on day 3 or day 5. In the second session, Dr. David discussed on the principles of vitrification and warming, and he said that the results of vitrification basically will depend on the cryoprotectant which has been used. And he also said that we need to look at the permeating cryoprotectant because that's going to cause injury to the cell, and basically the movement of these permeating cryoprotectants are stage specific, and that of the non-permeating cryoprotectants basically result in dehydration to prevent the formation of the intracellular ice. And we need to control the osmolarity as well as we need to look at the time required for equilibration, which is going to give us better quality of embryos post-thaw. Then we had Dr. Kelly, who spoke on safety and concerns about contamination of the open and closed system, and she said that we could reduce the toxicity of the cryoprotectants by ultra-fast cooling and warming. And she said that both open and closed systems are effective, though there is a theoretical risk of increased infection when we use the open system, but basically in practice we have really not found that higher incidence of infection when we are using the open systems. And she said it's not only maintaining the environment in the lab that is important, but we also need to maintain the environment in the cryo room. Then we had Dr. Balaji, who spoke about the developmental potential of a vitrified day 3 embryo, and he said that we can probably culture them further to blastocyst, and the number of day 3 embryos which would become a blastocyst will depend upon the quality of the embryo on day 3. And if we have the embryos which have more than 8 cells and they have started compacting, will form much better quality embryos and much more embryos as compared to those who are less than 8 cells. But he also said that probably when we have an embryo which is 3 cell, 4 cell or 5 cell on day 3, basically we should culture them to blastocysts because we will be able to identify the most competent embryo for an embryo transfer and thus prevent transferring of non-viable embryos. He also said that the live birth rate and the ongoing pregnancy rate are similar whether we vitrify the embryos on day 3 or day 5, and it's best, suppose you're going to do a day 3 transfer and not going to culture the day 3 embryos further, it is better to thaw them on day 2 and see that there is increase in the number of cells to see that there's further cleavage before we do the transfer on day 3. Then in the third session, we had 3 good talks, of which the first talk was on endometrial preparation, and Dr. Sara said that basically we could do either a natural cycle, a modified natural cycle, or we could do a stimulated cycle or a HRT cycle. And according to her, she said a natural cycle is best and it gives the best results. And this is basically because of the presence of corpus luteum, which produces certain molecular factors as well as vasoactive substances, which apart from the estrogen and progesterone help in the implantation. And according to her, the risk of miscarriages was also much less in patients who underwent a frozen embryo transfer in a natural cycle. We had a very informative talk by none other than Dr. Duru, the president of our society, and she said that the luteal phase support in the NFET cycle will basically depend on the endometrial preparation which is done for a FET cycle. When you're doing a natural or a modified natural cycle, most studies say that you really do not require a luteal phase support, but most of us empirically do give. But a stimulated cycle and a HRT cycle definitely require luteal phase support, and progesterone of more than 10 nanograms is required for an optimal outcome. She also mentioned that there's no consensus as to on which progesterone and how much of progesterone to be used as an ideal luteal phase support. Then we had Dr. Naina Patil, who spoke on adjuvant therapy and improving the endometrial receptivity, and she spoke about various factors going from aspirin to heparin, the vasodilators like sildenafil, vitamin E, nitroglycerin, pentoxifylline. Then she spoke on atozibom using HCG, GCSF, and several other immunomodulators. But all of these, and even the stem cells as PRP, but all this, most of the evidence for using all this is not there, or it is very, very low quality. And therefore, probably it's the clinician's decision whether they should use it for their patients or not. I did speak on the endometrium, and as I said that evaluation of the endometrial receptivity has more value as a negative predictor rather than a positive predictor. And I think in India what we use most is ultrasound, and it is better to add on Doppler to a normal 2D because it will help us in assessing the endometrial receptivity better. Probably ERA could be done in patients who have recurrent implantation failure, especially when the recurrent implantation failures is even after a frozen embryo transfer cycle. Then we had Dr. Kenny, who spoke on whether FET was a good option if we have blastocysts which develop on days 6 and 7. And we know that transferring embryos, transferring a blastocyst, if it develops from day 6 and 7, may not implant due to the asynchrony of the embryo and the endometrium, and probably FET may improve optimize the outcome after a frozen embryo transfer. But she also mentioned that the aneuploidy rate may be higher in blastocysts that develop on day 6 and 7, and therefore probably a PGTA would be helpful. Dr. Christos gave a very good talk on personalized embryo transfer, and he said that basically there's a lot of variation in the genes that are expressed in the proliferative phase and those that are expressed in the secretory phase. And in most of the reports or the studies which have been published, almost 70% of the patients have a receptive endometrium, whereas the out of the remaining 30, almost 90% have a prereceptive endometrium. And according to him, basically the miscarriage rate was lowest when we do a fresh embryo transfer as compared to a FET. And he also said that in some of the studies, which are the most recent study which was published, which was a multicentric study, that the live birth rate was not different between the fresh embryo transfer, FET, or a personalized embryo transfer, but probably there could be a higher cumulative rate with a personalized embryo transfer, which may then improve the outcome, especially in those women who have had recurrent implantation failure even after a FET. And I hope all of you all will join us tomorrow again for educational extravaganza. And I think all of you all would have enjoyed our session today, and you had a lot of take-home messages from today's sessions.
Yeah, I definitely would like to say a big thank you to all our speakers who have done a brilliant job. And honestly, it's been a long time since I've stuck on to a conference for so long, and it's been very, very interesting. I sincerely thank everyone, all our international speakers, our national faculty, and Madhuri, of course, and our coordinators who have been there, and Shobit, the technical team of Omnicurus. So we've had excellent support, and we've had an excellent meeting.